all those measures, and that's one of the big unknowns in this, which we're going to have to think about very carefully.
So one of the things that I understand the modelling says is that roughly, and it's obviously very, very approximate this, one can count on there being around 1,000 cases for every death that you have, which would mean that there's potentially now about 55,000 cases. Does that feel right to you?
That is what we've tried to get a handle on that in SAGE, and we put all the modelling information together. That's a reasonable sort of ballpark way of looking at it. I don't think, it's not more accurate than that.
And as I understand it, prior to the measures that were announced yesterday, your working assumption was that the virus was doubling, the number of cases was doubling every 5 to 6 days. But because of the very dramatic social distancing measures that have now been announced, it is possible that we could see the number of new cases actually start to reduce in 3 weeks' time. Is that what the hope is?
You would expect to see an effect of any of the measures after about 2 to 3 weeks. In terms of the sorts of presentations that we're picking up. Obviously the effect will start sooner, but you won't see it and be able to measure it easily for 2 to 3 weeks.
And judging on the evidence from other parts of the world and other countries that have followed this very sort of dramatic suppression and lockdowns in different flavours, does that mean that there is a possibility, of course we can't predict anything, that the cases could actually start to fall, the new cases could start to fall in 2 to 3 weeks?
Yes. That's what you'd like to see. The interventions that we've made, so these have all been modelled out, and it is just modelling, so we just need to be aware of that. These have been modelled out to say what effect they would have on the peak. So the first one that we introduced, case isolation, you would expect to bring the peak down by about 20%. The second one, of whole household quarantine, you'd expect to bring down by about 25%. The social shielding of the elderly has less of an effect on the peak, but a much bigger effect on the mortality, where you might expect it to be between 20 or 30%. And general social distancing measures, which, as you said, are quite extreme ones that have now been introduced, would be expected to reduce the peak by about 50%. Now, they're not necessarily all completely additive, but it tells you that together you should expect those to have a very significant effect on peak, and we should start to see the rates come down in 2 or 3 weeks' time. And the ambition in any outbreak is to try to get the R0 value down below 1, and that's the value at which anyone, on average, what one person would do in terms of infecting others. And at the moment, that R0 value is somewhere between 2 to 3, and the aim is to get that below 1, at which time things start to then decrease.
And just to be clear, that's not 2 to 3 weeks. That would take a bit longer than 2 to 3 weeks?
That will take longer, yes.
What would be a sort of hope there?
Difficult to get a very accurate handle on that, and that's where monitoring becomes incredibly important. So I think as we enter this next phase, and having made these very significant interventions, it's going to be really, really important that we can get the good data to monitor the effects. That's important for 2 reasons. One is we might need to do more. And I've been very clear from the beginning, there's a whole range of things that we need to look at. All of them are on the table, that we might need to do more. And of course, we might also, at some point, need to back off. We will need to back off at some point. We need to be able to monitor, well, what's the consequence of backing off?
But just appreciate this is the upside and there are no certainties in this. But if yesterday's announcement bears the fruit that you're hoping, the total number of deaths, rather than being in the hundreds of thousands, could potentially get below 20,000, which is still a huge number of deaths, but is nonetheless a much better picture than many might have feared.
That is the hope, that we can get it down to that. And to put that into perspective, every year in seasonal flu, the number of deaths is thought to be about 8,000 excess deaths. So if we can get this down to numbers 20,000 and below, that's a good outcome in terms of where we would hope to get to with this outbreak. But I mean, it's still horrible. I mean, that's still an enormous number of deaths, and it's an enormous pressure on the health service. And having spent 20 years as an NHS consultant as well as an academic, I know exactly what that looks and feels like.
And just before I bring my colleague in, just one final question about what we have come to understand about the disease. Most people understand that the people who are at risk are either people with a long-term condition or older people. But in the Netherlands, we understand half the COVID-19 patients in intensive care are under 50, including one 16-year-old. Have we had any deaths in the UK from people who are young and without long-term conditions?
I don't have all of the clinical information because that's privy to the Health Department, NHS, and the Chief Medical Officer. So that's really a question for them. But it is obviously a very important thing. Most of the deaths, I know this for sure, the vast majority of the deaths in this country are people who are elderly, who've got pre-existing conditions. I can't tell you, because I don't know, whether there are any exceptions to that.
And are you aware of any doctors or nurses who are currently in intensive care because they've picked up the virus from patients?
Again, I'm not privy to that sort of information. That's something, and I know the CMO is being very careful, rightly, about protecting confidentiality of patients. But I would say that the one of the points maybe underlying the question, which I think is important, is these viral infections can adapt and change as we go along, and we must keep an eye on everything from clinical picture through to outcomes through to different ages to make sure that we're always dealing with what we think we're dealing with.
Luke?
Just in reference to the questions over the percentages you gave, what's the confidence interval you're using on those? Because if it's nice and narrow, then it doesn't matter.
Very wide.
Can you give us a ballpark of therefore where you're going with?
Well, so the range, for example, for the first measure of case isolation was between 15 to 25, I think. And even that, I think, you would take as a sort of a model, but not a precise estimate. So I think all of the confidence intervals in these things are quite wide.
Thank you. In terms of the monitoring side, you've mentioned that. With the change in policy around testing, can you explain how you expect to monitor if we're not doing as much testing? I think people struggle with trying to see that picture.
At the moment, the UK has done something like 44,000 tests, which I think is in the top 3 or 4 countries in terms of testing, and Public Health England have got a capacity of about 4,000 or so per day. That clearly is not going to be enough going forward, and one of the recommendations from SAGE is that we really do need to get our testing in the right position to make sure that we can monitor this effectively. At the moment, the priority for testing is patients in hospital in intensive care units, those with respiratory illnesses in hospital and pneumonias in particular, isolated cluster outbreaks to make sure that we can understand what's happening there, and the GP surveillance system to try to get a handle on what's going on in the community. As the capacity ramps up, and there's a very big effort going on to try and ramp that up, that will be extended to other groups, and ideally you get that very wide. The second form of testing that I think is going to be incredibly important is serology testing. So looking for antibodies of people who've had this infection. And the reason that that's so important is all we can do at the moment is detect somebody who's got active virus that they're shedding. And there's some evidence that if you're asymptomatic and you're infected, the test isn't at all sensitive. So we're not even nobody's really able to pick up the asymptomatic people very easily. So with an antibody test, we'd have a much, much better handle on the proportion of people who are asymptomatic, the true number who've had it in the community already, and I think we'll get a better handle on what happened in other countries, in China and Italy. It would change a lot if we could understand that.
Okay. I was just going to say, thank you for that. One of the groups you missed on that, and my colleagues in primary care and indeed the hospital are most concerned is they're having to isolate without any symptoms, and suddenly 3, 4, 5, 6 members of staff drop out of a surgery. Their argument is, why aren't we being tested? I want to get back out there and help. It would help a lot. What do you say to them in answer to that question? Part sounds like capacity, but is there any other reason around that? And what can we do to rectify that?
I think the next group of people that I know, PHE, and to check with the CMO to make sure that this is exactly where they want to go, is to try and get to sort of key workers to make sure that they're tested, and obviously healthcare workers would be absolutely there. So I think as the capacity ramps up, that's where you'd go next to make sure you can do that, and I think that is the plan.
And with around that, it'd be useful to know most people will recover. Let's not forget that this is flu for most people. Could you talk us through how quickly they recover, when they could return to work, and then also that cohort, and if you've got any ideas? It seems like you have a response phase, you start to improve, your antibodies fire off, and you get this cytokine release that causes an ARDS, so your respiratory problems, and that's when people crash. Is there any indication of how you're spotting? Do those people have a sign? Is there a test for them? So there's two parts to that question.
So you're right, and very early on, I spoke to colleagues that I've known and worked with in Singapore right early in their outbreak, and it was clear from them that there was this 2 phases of illness. The vast majority of people, as you say, get a viral illness which gets better, so that by 7 days they're feeling better, often by 5 days they're feeling better. Some of them go on to get this second phase, which is the immune reaction. And that immune reaction seems to kick in at around 5 days. It's characterized by shortness of breath, failure to get better from the first round, and then a deterioration. It's important that this isn't, at that stage, due to active viral replication, so much as the body's response to it. And so, the idea that antivirals are going to work then is probably wrong. They might work very early on. What are the features that make people more likely to be in that phase? Some evidence that it's initial dose of exposure, which is why healthcare workers potentially stood a risk at the beginning if they were being exposed to very large doses, and pre-existing diseases and age, which presumably is a surrogate for pre-existing diseases as well. So that's sort of at high level what we know about this at the moment, and it does have quite big implications for how we think about treatments.
And could you just explain for the public then, for the people who are getting better, how do they develop an immunity, and when can they return back to work? So if they do their 5 days, they're feeling better, are they able to go back out into the workforce and they're protected so that they can carry on working?
The vast majority of people seem to stop having significant viral shedding around 7 days. Some may go on a bit longer. That's why the 7-day isolation period was recommended for individual cases. Some may go on a little bit longer, but for the vast majority of people, the viral shedding has decreases quite rapidly after about 4 or 5 days.
Can I just go back to the comments you made about testing? Because I think there is quite a lot of confusion about this. So first of all, the words of Dr. Tedros, the Director General of the World Health Organization, he said, you can't fight a virus if you don't know where it is. Find, isolate, test, and treat every case to break the chains of transmission. But on Friday, we stopped community testing for people with mild symptoms. And Chris Whitty said people who were in the community with a fever or cough do not usually need testing. And a GP who, for example, self-isolates because his daughter has a fever is not now able to get a test. So are we now saying that it is the priority to test as many people as possible, and that what we did on Friday was an absolutely temporary measure, and we intend to reintroduce community testing as soon as possible?
I think what Chris said, or I think what he meant, if he didn't, I think it is what he said as well, was that that's what we have to do with the capacity we've got. We need to use the testing in the right place at the moment. And we simply don't have mass testing available for the population now. And there's a big effort going on to try to get that in place as quickly as possible to be able to manage this. And people are producing all sorts of tests which may be much more readily applicable in the wide community. Those are all being looked at by Public Health England to decide which ones really work and how they might be thought about getting those out. But the point I think Chris was making, and he'll obviously speak for himself, but the point I think he's making is that in a situation where you've got a capacity to do a certain number of tests, the priority should be the areas that I mentioned.
But how it came across was that there was a change in approach and that we were focusing our testing efforts from now on hospital and hospital cases. But I think what you're saying is that's not the case, and it is absolutely the intention as we ramp up our testing capability that we will go back to testing in the community. Is that the case?
Well, what I can tell you, and remember I am the government's chief scientific advisor, so I'm advising, and SAGE advises, is that we need to ramp up testing for all the reasons that you've mentioned. There are two things that are critical: ramping up testing and making sure we have great data flows. Those two things are very, very important in how we manage this, for both the interventions and, as I said, for removing the interventions.
So if I just look at some other countries that have taken the suppression model that was published in the Imperial paper this morning, which we're now following, the one that most people think has had the greatest success is Korea. And they actually had a more serious situation than us because they had a super spreader. But if you look at their testing capacity per head of population, they're testing 10 times more people. So is that the kind of scale that we are looking at, sort of not just increasing it, I think, from 5,000 to 10,000 a day, but a massive increase?
I think we need a big increase in testing.
Right.
And that's what I'm pushing for very hard. And everyone's working hard to try and make that happen. And the other thing is, I think what you don't want is everybody coming to the hospital to be tested. I mean, that's the worst possible thing. So the quicker we can get to something that looks like a true community-based test that people can do easily, the better.
And do you have any sense of timescales on that? Because I think a lot of people are concerned that when we're not testing in the community, we won't have the data to actually know what the spread of the disease is.
First thing to say is the measures that have been put into place, so case isolation and now whole household quarantine, are the measures you would take anyway. So they are the things, if you like, the potential downside of what we're doing at the moment is we're putting people into whole household quarantine who might not have coronavirus. And so they may have to do it more than once. But we're doing the right thing if you have got coronavirus, and we're doing it for the whole family. So in terms of the actions, it doesn't matter. In terms of the speed of test, there are tests now. Lots of people claim to have tests, and there are obviously very good laboratory tests which can be done. There is a lot of work going on at the moment, I know, in Public Health England, NHS and DHSC to select which tests we should go for and how that can be ramped up, possibly, and I think quite likely, by the private sector, so we can get things out there fast on the community side, having the other part of the testing really controlled by Public Health England for the hospital and the other bits that need to be done.
And then just a couple of brief final ones from me in this section. If we look at some of the countries that have followed the suppression approach successfully, and I think Taiwan is another one alongside South Korea, one of the things that is very striking is their use of mobile phone technology to follow someone who turns positive for the virus and then trace all the mobile phones that have been near that person. Now, obviously, there are civil liberties implications that need to be worked through, but if that was shown to reduce lives by increasing the speed at which you isolate potential cases, as a scientist, is that something you would consider recommending?
I think that would have been an absolutely brilliant thing to have had in January. So at the beginning, that sort of approach makes total sense. It may well have utility later on, and it may well have utility as you go to a situation where you get the R0 down and then you want to sort of see what happens when you release. So I think those technologies do have certainly a place that needs to be looked at carefully and implemented. And I know, again, people are working very hard on that sort of approach. And as you're probably aware, I think that was used quite extensively also in China through the WeChat app that they have.
And finally, just from me, could I just ask you a question in your capacity as a former NHS consultant and not just chief scientific advisor? Obviously, and Luke alluded to this, staff can't look after patients if they themselves are ill. And a lot of staff are worried about the lack of protective clothing, protective equipment. And I just wanted to read you, here's a comment from one doctor who is currently treating coronavirus patients in a major UK hospital. And he says, 1 week ago, I was wearing full personal protective equipment. Now we've been told not to bother with any of that, contradicting WHO guidance. I'm terrified. I can't bear the thought of infecting other patients with a disease that could kill them. What's your reaction to that, given our determination to bring down mortality rates?
Well, I think that is a question that really needs to go to the NHS as they think about how they organise the response to this. I think it is important that we get the proportionality right in terms of where protective equipment's needed and where it's not, because one of the things that is a risk is that if we go to the wrong place on protective equipment, actually it hampers all sorts of other parts of healthcare delivery. So I don't think that's really a question that I'm in a position to answer, but I think it is one that the NHS could answer.
Okay, thank you. Dean.
Thank you. Thank you, Sir Patrick, for being here today. I have two broad areas of question. One is around data and one is around schools. On the data side of things, I've had a lot of scientists, a former scientist myself, asking me why we aren't releasing open data on everything we possibly can, given the number of brilliant brains, not just in academia, but also in business, who are, for use a phrase someone shared with me the other day, chomping at the bit to try and help and look at the modelling. I was just interested to get your view on why that hasn't happened and what will be happening on that front.
I think there may be two bits to that question. Yeah. In terms of the data, I think the data is being released by PHE and NHS, and those are the data which everybody are using, and they're data collected from around the world. And then there's a second question about the modelling.
Yes.
The modelling, clearly it's been rather fast moving. We've had all sorts of different modelling things that have gone along, and then Neil Ferguson released his paper yesterday, and we're releasing the modelling that's been done and the various other parts of the science input to SAGE this week to try and get that out in the public domain. But the data, I think in terms of the multiple brains on it, it's the data access which is important, and that data access needs to work well, it needs to be open, it needs to allow people to sort of crunch the numbers and come up with the answers that they come up with. The models and the codes will be made public by SAGE and by the academic groups that are doing it. I mean, it's not a government organisation that's doing it, it's the academic groups that are doing the modelling, and that will be released.
And in terms of that, is there just one of the other questions I've had, and this might be a naive question, but is the modelling that we're using in the UK the same modelling that's being used throughout the world, that's given it's a global pandemic? Is everyone using the same approach? And if so, why in some cases do we seem to be making slightly different decisions from other countries?
I think modellers are using, I mean, as always, they use different models depending on what they think are the most important variables to put in and how they treat those. I do know that the modellers that we use are being used by others as well, and in quite a lot of demand, so that other countries have either used the modelling that's been done here or asked the modellers to be involved in things. So I don't think there's any great difference in terms of how modellers have approached this, but some countries have got fewer modellers and some have got more, and the UK happens to be a country which has got extremely strong science right the way across the board, including in modelling.
And regarding that modelling side of things, we've seen during elections in so many different areas that data is used across both for predicting disease and so on, but also can be used to identify vulnerable areas, vulnerable people, perhaps older people in certain areas. Is there a plan to start to look at this in a slightly different way where we can predict where potential vulnerable people might be, so that we can ensure that volunteer networks and support is given to them ahead of time?
I think that I know that, for example, GHSC are using the data they've got to try and understand where the most vulnerable people are in order to make sure they get the specific advice they need. And so I think that will happen, I guess, within the department and within the NHS. I think the other question for modelling going forward is to what extent it can help understand where capacity is being reached and where therefore there are more stringent interventions that might need to take place in one area or another in order to manage this. And I think this is going to have to be an actively managed process to keep on top of it, which means I come back to my 2 points, that testing and data flows are going to be critical to get this right.
And thank you. And on the school side of things, because this seems to be the biggest topic in many MPs' casework and inboxes, could you give I understand that closing schools might mean that children then have to be looked after by grandparents and so on. But what I'm hearing is that this is already happening, but on a lower level already. For example, I was told a story just this week where one school is testing the temperature of children as they walk in the door. If their temperature is too high, the parent then has to literally find somewhere for them to be looked after. In many cases, that is grandparents. So could you just give a really clear view on why schools aren't closing now, why we're doing it differently from other countries, which seem to be quite commonly closing schools, and if schools are to be closed, what the plans are around that?
When we looked at all of the interventions, we looked at the ones that had the biggest impact first, albeit with the variability that we talked about, and those that have less effect. And school closing was definitely a bit lower down the list than some of the ones that we've announced. It doesn't mean it doesn't do anything. It would have an effect. But it has all sorts of complicated effects as well, including the one that you mentioned of potentially leading to children being with grandparents and so on, and of course also causing an enormous problem not just for the workforce generally, but for the workforce in the NHS as well. So it's a complicated one, and all I can do is give the sort of science advice on that in terms of the effect. I think as you look across the world, for example, Singapore hasn't closed schools. It's introduced some different measures in schools. Taiwan, I think, didn't close schools in managing this. So there's been a variability across the world in terms of school closures and whether that's been part of the approach or not. It's absolutely on the table, as the whole suite of measures are. The evidence base is there to suggest where it might work and where it doesn't work. And decisions will, I'm sure, be made at the time that they need to be made around school closures, which is one of the things, one of the levers to pull to try to get on top of this at the right time. But I say it's not without quite complex consequences.
Yeah. And just on that, two more brief questions, if that's okay. One is around school children. I have a daughter myself. A lot of kids are talking around this. They're not, they're not ignorant of the situation. And one of the concerns also is around mental health. Around children, how they're being taught about this in schools. They're worried that they're going to give their grandparents something that could potentially harm them. Is there any discussion around mental health around this? Of course, physical health is absolutely key, but mental health and the concern of the repercussions of this over the coming months and years could be quite high.
I think that's one of the big worries. I mean, we need to remember that the health service is going to be under pressure during this process, and there will be the direct illnesses and tragic outcomes relating to the virus. There'll be the indirect, due to the fact that other people may not be able to get the care at the time that they need, and there will be the consequences on things like loneliness, on people feeling isolated, on people not being able to get enough exercise and the other things they might want to do to keep themselves healthy. And mental health is definitely part of that. So I don't think, and that's why, when we look at the measures that were announced yesterday, that is a very substantial set of measures with a lot of consequences, and it's why also this is something for all of us. It's our ability as a society to help each other during this time, which is going to be incredibly important. And I think that's where we will see a lot of people wanting to help in order to try and get through this. But it's not an easy situation, and it's going to go on for some time.
And very finally and very briefly, in terms of schools, I imagine you must have talked at some point about schools potentially closing.
Yes.
If that were to be advised, do you foresee it being an overnight decision, in which case tomorrow morning children won't be going to school, or would it be a staggered thing, so teachers, parents and children get a chance to adjust and know what their plans will be, so that kids aren't just given to grandparents, as it were?
I think that's a decision for ministers to take as to how they would make a decision about closing schools and in what way they would choose to do it.
Okay. Thank you.
Paul.
Hello, thanks for appearing before the committee today. Just on schools, I've just got a couple of questions just from the exchange you had there. I've had a number of inquiries from teachers who have emailed me about the risks that they feel they have about their exposure to the virus. What would you say to them?
I think all of us, of course, and that's one of the reasons we have given the advice on the measures we have, want to try and reduce the transmission, and that's the social distancing measures. There will be groups of teachers and others who are particularly at risk potentially, and I know this is something that the CMO is looking at hard and thinking about the right advice for those people. I think for everyone in the public sector working, and those continuing to work in aspects of the private sector as well, clearly, the more we're going out and about, we do all carry some risk of catching this. To go back, though, to the point that was raised earlier, for most people this is a mild illness, and we just need to remember this. For the vast majority, this is a mild illness. So I think advice around specific measures for vulnerable groups, those most at risk, is what NHS and DHSC are producing.
Yeah, and I've also noted that there's been some talk of advice given to those who are pregnant. What would you also say to those, and I declare an interest in the sense that my daughter is just 12 weeks old, but to mothers and carers for very, very young children, babies?
I don't want to dodge the question so much. Say that's really a question for the chief medical officer.
Okay.
I mean, I know I'm a doctor, but
No,
I haven't practiced for a long time, and it's not. I don't want to be giving advice that's really the thing that the CMO and the NHS should be giving.
Okay, that's fair enough. Is the government engaging with those scientists that disagree with your plans?
Oh, completely. I mean, absolutely. If you think SAGE and the way SAGE works is a cosy consensus of agreeing scientists, you would be very mistaken. It is a lively, robust discussion with multiple inputs, and we don't try to try and get everybody saying exactly the same thing. The idea is to look at the evidence, come up with the answers as best we can. There are subgroups that work and feed into SAGE. And the membership of SAGE, I should say, changes depending on what we're discussing. So it's not as though it's the same group of people that always discuss all the topics. There are members that come for specific items.
And you made it clear that your role was to advise. How much do you believe that the current strategy that's being driven by scientific evidence, and how much by behavioural science, and how much perhaps by economic interest?
Oh, I think the advice that we've given from SAGE, which is based on modelling, virology, clinical, behavioural science, actually even other areas of science as well, that goes to the government, has been really carefully listened to, and has not been in any way, from our perspective, overlain with economic considerations as a reason to change the advice. Okay. So it's very straight advice. We're interested in two things. We're interested in saving lives and protecting the most vulnerable. And that's been the driving force that will continue in all of our outputs.
And just finally, other than what we've seen in terms of the regular conferences, I think daily conferences we're going to see from now on, what strategies are there in place to ensure effective information is given to the public and other organisations on the essentials of the plan?
Yeah, again, that's not really a science question in the sense that I can't, I'm not in charge of the communications of it, but
No, sure.
I do think it's critically important. I mean, it's very obvious that this is complicated, it's frightening. People don't know what to do sometimes, and therefore the clarity and the ability to keep repeating the same thing in a way that people can understand, I think, is crucially important. And all of the behavioural science would suggest that we've got to get the transparency right, we've got to get the communication right, we've got to trust that actually people want to know things, they want to know about this, and they want to be able to be empowered to make their own decisions on this. And I think those are some of the key things in terms of how we communicate this.
Thank you. Laura.
Thank you. There were some very serious measures which were imposed yesterday. You mentioned earlier that what happens when you release them is the big unknown. And you also said that we've got to look at what is the consequence of backing off when we think about taking them off. Can you just talk us through what the process is for these measures being lifted and when you think that might happen?
Well, we're just at the start of implementing them, so I think we're nowhere near talking about releasing them. They're about making sure we do them properly. And as I said yesterday, and I've said again here, there may be other things that needed to be added, and we've talked about one of them here. There may be others. When we get to the stage where we've got the outbreak down to a level where we know we can keep it below the NHS capacity, which is the aim, and when we're happy that that can really be maintained properly, that's the time to start talking about how you might release it. And there are various ways that you could think about that in terms of backing off a bit, seeing what happens, putting things back. And that, I think, is the sort of approach that might be necessary in due course, but we're not there.
Do you have a figure in terms of that NHS capacity that you're working to?
Well, the NHS capacity will come from the NHS, so they will provide the figures as to what their capacity is, and then the models can obviously, and the data streams can flow into that to say, well, where are we against that capacity?
Fine, so there's not a number now that you have that you know will be the case, that is the capacity that when you think you can manage that number, you will lift the restrictions?
Well, so there are two bits to this. That there's the infection itself and how common that is and how much that's going to increase or decrease.
Yep.
And then there's the capacity of the NHS, which they're working on incredibly hard to try and increase. And so that number's moving, both numbers are moving, and obviously both of those numbers are the ones you need to keep an eye on as you think about when you might be at a stage when you can think about backing off.
There are some people that are suggesting that these measures may last 18 months. Is that something that you think might be credible or not?
18?
18 months, yes.
I don't know how long these measures are going to be needed for. I think the modelling so far suggests that it's certainly not a couple of weeks. And one of the things that I think if you look at some of the approaches that have been taken, the assumption that you might just close things for 2 weeks and start up again is not correct. It's going to be months. I don't know how many months. It's going to have to be data driven. In other words, as you see things changing, you might need to do more, you might need to do less. And by the way, that might happen quickly, just as it did over the course of the last week.
Yeah.
That isn't because there's a sudden change of strategy, it's that you're responding to the information you've got in order to change, and that's what we need to be prepared to do. And I think we're going to have to be equally nimble as we think about backing off again, and we're going to have to try it. And one thing is, for sure, we haven't got immunity to this virus, and therefore, as we back off, it may come back again, and we're going to have to manage that very carefully. And we're going to have to hope that we can get through quickly with some of the other interventions as well to try and get on top of this. So vaccines and the other approaches that are being taken, which I have to say, I think there's been really remarkable efforts and progress in some of those, but we're still a long way off.
And in your conversations internationally about countries that are further ahead than us, do you have an idea of what their plans or what their approach is going to be to actually lifting the measures? For example, potentially China.
Yeah, not really is the answer. I think everyone's asking the same question, and you look at some of the scientific papers coming out from China and elsewhere, people are looking at what could happen, but we don't know yet. And I think all of the evidence from previous epidemics, and this type of infection would suggest that you can't avoid this bubbling back up again when you lift off. So that's what we're going to have to be aware of, and that's what we're going to have to try and manage.
And when you say bubbling back up again, do you mean a spike, or this being something like we would understand as seasonal flu?
Well, seasonal flu is, in a sense, a spike every year, and that may be what this ultimately becomes, something like that, and that may be what we need to plan for. So I mean, there are two ways that you can think about this. So I think if you withdrew all of the measures immediately, you'd probably have a lag phase and then a peak. Mm-hmm. If you withdrew some of them, you could begin to sort of see, is it just sort of creeping up, and you're beginning to see an effect, and you might then reimpose them. So I think that's why I refer to sort of an agility in managing this is going to be quite important, I think.
Thank you.
I've just got a couple of questions from our colleague James Murray, who's not able to be here. But I wonder if I could just follow up on one of Laura's questions there, because I think the thing that's puzzling people who look at other countries, China officially announced they think they're past the peak. South Korean foreign minister was on TV at the weekend saying that she thinks that South Korea has passed the peak, and they seem to think they passed the peak with less than 1% of the population being infected. And they're very realistic. There could be second waves, third waves, but they don't seem to be expecting it as much as you do. And I was just very struck by the phrase you said just then. You said if you look at all the evidence, you can't avoid concluding that it's likely to come back. And I just wondered if you could explain to non-scientists, because I think the Chinese view, the Korean view, seems to be that it could be something like SARS, for example, which just burns itself out when the reproduction rate gets below 1. Why is it that you're unfortunately so certain that it will come back?
So I don't want to be a merchant of doom on this, but I think the transmissibility of this virus is very, very unlike SARS. I mean, SARS was not transmissible in the same way as this, and it had a very high mortality rate. This has got actually a rather lower mortality rate. It's got a very high degree of mild infection, and just today there was a paper that I was reading from China suggesting that something like 86% of the infections in Wuhan were not ever detected before at the time. So there's a very high degree of transmissibility. All of those characteristics from the evidence from everyone we've heard from suggests that when you lift, you're going to get something coming up again. Now, I can't tell you how big that's going to be, and we may be lucky and maybe it doesn't, but everything suggests that that is what you would think in an outbreak like this, with a virus like this, with the sorts of properties, would be what you would expect to see.
Thanks. And then I'll come to you in a sec, but I just got a couple of questions from...
And by the way, I hope they're right and it doesn't. I mean, that would be a perfect outcome, and like all scientists, I'm very happy if I'm wrong on that and it doesn't come back.
So these are from James Murray. His first question is, more than other countries, the approach in this country continues to segment the population with different levels of isolation. Could you explain very specifically why you've chosen this route rather than more blanket approaches with reference to scientific evidence, behavioural science, economic interest, and so on?
Well, we've said everything's the same for case isolation. Everything's the same for household quarantine, asking people to stay together in the whole household. We've given the same group of social distancing measures for everybody and said everybody should take those seriously. They are particularly important to be very stringent about them if you're over the age of 70 or have another illness. And then we've taken one group of much more vulnerable people with serious illnesses that can predispose you to viral infections and to other things where there will be specific advice. And I'd be surprised if people like that weren't getting specific advice in other countries if you're particularly susceptible. So I think we've gone for pretty similar, actually, advice across most of the population.
Okay. And just to be clear, because there was a bit of debate about this yesterday, for over 70s who don't get contacted by the NHS as being someone with a long-term condition that makes them especially vulnerable, could you just explain what sort of changes in their lifestyle you're hoping for? I think perhaps the easiest way to do this is to say, what are the kind of things they might do now that you're asking them not to do going forward? These are the healthy over 70s.
Avoid crowded spaces, avoid gatherings. Don't go to the club that you normally go to where everyone's sitting around together. Reduce travel. Try to avoid unnecessary travel. Don't go out to do your usual things in terms of going to the shops and things unless you absolutely have to. So if somebody can deliver it for you, so much the better. And so there are several things they shouldn't do that they're doing now. What Chris Whitty has said, and I think it is an important point, is you could go for a walk around the garden, or you could go for a walk avoiding close contact with people, so that we're not asking everybody to be completely separated. But there is quite a big change that's being asked for, and the specific guidance is on the DHSC website.
But just very specifically, what about going to Sunday lunch with their family and their grandchildren? Yes or no?
Do it.
Shouldn't?
No.
Okay. Yes, I've just got one more from James Murray, and then I'll come to... Oh, sorry, on that point. Yes, please do.
Just on that, exercise is going to be key. So are you saying, when you mentioned about walking in parks and so on, is that the sort of thing where if someone wants to go and play golf, or, you know, the sporting exercise that they can do en masse, but where they're not close together, they could still do?
I think the advice is to try to avoid close contact, to try and reduce social contact. I think realistically, a walk is okay if you're keeping a distance, but it's not if you're going to be in close contact with people.
So realistically, it is possible that over the coming months, healthy people over 70 could go out to parks as long as they're keeping away from each other, effectively. So they could do group exercise, but be 2 or 3
Well, I don't think group exercise, no.
No, okay.
So I think, again, we're straying into, into areas that are very much sort of NHS advice and DHSC and the CMO advice. But I mean, I think, you know, this could go on quite a long time. I think it's quite important that we get it right. And the danger is in crowded places, gatherings where you've got a few people in a enclosed environment. Those are the sorts of things that we're saying don't do. Don't go out to the shops if you don't have to. Really make sure you do it only when it's absolutely essential. There's no other alternative. And I'm afraid it is avoiding those sorts of social interactions which are such a crucial part of everybody's life. I'm afraid we're asking us all not to do that.
Sure. Thank you.
And then a final question from James Murray. This is slightly touching on what you said before, but I just want to ask it because he's asked me to ask it. Given that the advice is slightly different for the under 70s and the over 70s, does herd immunity and the concept of herd immunity play any role in the thinking with respect to that slightly different advice?
Oh, no. I mean, in fact, the advice is the same. It's just saying do it more stringently in the over 70s. And the whole point about the over 70s and the vulnerable groups, most of the measures we're talking about are about trying to protect everybody. They're about trying to prevent the spread of the virus in a way that puts people at risk. For the elderly and vulnerable, it's about protecting yourself. So it's a rather different set of messages. I mean, clearly it's also part of the first message because they're not spreading it either, but it's very much about protecting themselves.
Thank you. Luke?
A couple more questions about evidence, if that's okay, particularly around medications. So a week ago, common blood pressure medications, things like lisinopril, ramipril, candesartan, a lot of people are on them. There was some concern that there could be a problem there. Yesterday, France announced that there could be a problem with ibuprofen, and the BMJ, you probably won't have time to see it today, have produced an article today saying avoid it. I wonder if you could comment on the evidence around both of those and whether you think that's advice. I appreciate we're straying to medical advice.
Yeah, no, it's fine. I mean, I can talk about that from a sort of scientific perspective.
Please.
And I spent quite a lot of my life trying to make drugs and making drugs, so I do know about that. But I think There's theoretical reasons around
Yes.
ACE inhibitors which are quite interesting, but I don't see strong, compelling data yet to know what the answer is to whether that's real or not, and that's being looked at. And the ibuprofen example, again, it may or may not be right, I don't know, but the sensible thing to do, I think, would be to say, well, don't take it at the moment, take something else, paracetamol or something.
Yeah. Thank you. And one final question. What surprised you the most about the situation we're in?
Well, I don't think any of us have seen anything like this. I mean, this is a first in not just a generation, but potentially the first for 100 years. And so none of us have seen this. It's not like an outbreak of something like Ebola, where it's a very different type of disease with a very different type of death rate and a very different set of criteria around it, circumstances around it. This is a daily changing, unique situation where we're learning as we go along. We're going to have to invest heavily in science. We're going to have to research hard to find out why some people are getting ill, the real illness, why some people have a particular cytokine storm, why people get better quickly in some cases, what the vaccines are, what the tests are, what the treatments are. I mean, this is a really big, intensive research effort. And so what surprises me most, it's that, you know, as always in medicine, you find out there's a lot you don't know.
Thank you. Yes, Dean.
Sorry, I just wanted to come back on the data question. We talked about modelling and so on earlier. Just occurred to me from some of the comments you made around the use of data for public information, but also the collection of data. Testing is one thing, but also making sure we're doing the right research relies on the right data being collected. I just wondered whether any conversations have happened with places like Facebook and Google and so on to enable people to track their own journey when they've got it, as it were, in terms of the illness, and also whether you're looking at data from, say, hospitals or local areas where they can say, look, we're nearly full, so that people can see the capacity that's going on, so that it's a shared data and there's a responsibility to share that data.
So three things on that. First is that the research community, I think, has stepped up really quickly to some of this, so that we've had meetings, which I've called every week or so, with UKRI and the Research Fund as Wellcome Trust and so on, to try and get money out of the door quickly to get this going, and that's worked really well, and those organisations have worked brilliantly there, I think. I think the tech companies are all over this for the reasons you said, and they've been talking to government and to other governments about how we can do this. And yes, absolutely, the data flows of what's happening locally are going to be critically important to understand where NHS capacity is filling up, where there's an outbreak that's got a bit more, where there's one that's got a bit less. And I said yesterday, you know, London's ahead of the rest of the country in terms of where it is on this outbreak at the moment. Mm-hmm. Others will catch up, and we'll see it in different times at different places. We need to be able to get the right data flows from the NHS, who are working incredibly hard on this, and Public Health England, who've done an amazing job on their activities so far, to make sure we get that right to be able to monitor this properly.
Thank you.
Any other questions? On which note, thank you very much for sparing the time, and thank you for your valiant efforts. Much appreciated.
Thank you.
very much indeed for coming. We completely understand how busy everyone is. And I think the first thing that the committee want to do, actually not just on behalf of us and Parliament, but on behalf of the whole British people, is to thank you, and through you to thank the whole NHS for the absolutely extraordinary efforts they're making. I mean, it's a bit of a cliche to go on thanking the NHS, but I think when people see what's happening in Italy on their TV screens, they know what the NHS is preparing for at the moment, and we just feel incredibly proud to have such dedicated staff on the front line. So if you could pass that on, we would be extremely grateful.
So, thank you.
I'm going to ask a few questions to start with, and then I'll hand over to colleagues. And I thought I might start, if it was questions about capacity, would that be Keith or Amanda, would you think?
Any of us.
Let me start, Keith, with you, if that's all right. And and I just wondered, what is the current number of general adult acute beds that we have?
Shall I maybe start
Yeah,
on this,
sure.
Chair, and then we can divvy up other things. So, as of today, we have 98,000 general and acute hospital beds open across the English National Health Service.
And the current occupancy?
The current occupancy actually has been falling, and as we speak today, is at under 90%.
Right. And of those, how many critical care or intensive care beds?
So we have 3,700 critical care beds for adults in play at the moment. And obviously, as part of our readiness for the likely influx of more coronavirus patients, we are going to be taking concerted action across the whole of the NHS to free up up to a third of the general and acute beds. We want to enable perhaps 30,000 of those 100,000 general and acute beds to be available for coronavirus patients. And today I am asking the NHS to do three things to get us into that position to be able to receive those extra patients. First of all, we are suspending elective non-urgent surgery with an assumption that that will be suspended everywhere from 15th of April at the latest for at least 3 months, but with discretion for hospitals to take action earlier if they need it, either because of the pressure of patients being admitted or in order to adapt their facilities or train their staff. Secondly, we are working intensively with community health services and social care, using some of the flexibilities that the emergency legislation before Parliament will mean to unblock some of those discharge processes, as well as some of the extra funding that the Chancellor announced in the budget. And thirdly, we are working with the community hospitals, the intermediate care providers and the independent hospitals to bring that capacity online as well for coronavirus patients.
Thank you. Just cutting to the chase, the modelling that was published this morning by Professor Ferguson at Imperial, which I think the government is working on, basically has an assumption that 4% of COVID-19 patients will need a hospital bed, and of those 30% will need a critical care bed. If you take those assumptions and then you combine it with the measures that were announced yesterday, which are expected to dramatically slow the growth of the virus, are you now confident, combined with the other measures that you've already been working very hard at, that we will have enough intensive care beds for people who need them?
Well, this is obviously an unprecedented global health threat. Unmitigated, there is no health service in the world that would be able to cope if this virus let rip. And therefore, it is crucially important that the measures that were set out by Public Health England and by the government yesterday take effect in order to reduce the infection rate such that the peak pressure on the NHS is moderated. In the meantime, what the NHS is doing, of course, is pulling out all the stops to make sure we've got as many staff and beds and other facilities available, including critical care, for that peak in demand.
So I'm not trying to ask you to have a crystal ball, but on the basis of the modelling and what it would be reasonable to think would happen as a result of yesterday's measures and also the preparations that are being made, do we have some degree of confidence that as things stand at the moment, we will have enough intensive care beds?
Well, those measures will certainly make a big difference and in our view were absolutely necessary. But frankly, we're going to have to keep this under review. And if it turns out that further measures are required in order to reduce the number of people who get this virus, then that will be something that policymakers and government will have to consider. In the meantime, what the NHS is doing is making sure that not just overall hospital beds, but particularly intensive care beds, operating theatres, recovery bays being repurposed, mechanical ventilation about which there's been a lot of discussion, other facilities across the hospital sector, that they are as expanded to the greatest possible extent as they can be so that the NHS can do all we possibly can.
And actually, just with respect to the, I think the second of the three things that you just announced, I had a message from a hospital in Surrey about a big problem that they were having in terms of discharging palliative care patients to care homes and hospices, because the care homes and hospices didn't want to take patients unless they knew that they didn't have COVID-19. And is this a problem that we have a plan for, a solution for? Will what you've announced today help deal with that issue?
We are testing patients who are emergency admissions to hospital with respiratory or ?COVID type symptoms. So we have that those diagnoses now available to us. And obviously, as we look to discharge patients through the extra community health services, potentially palliative care services, social care services, we will have to tackle that. But I don't know, Steve, whether that's something that has crossed your radar particularly.
No, but I think Simon's absolutely right. We are testing those individuals in hospitals who have a wide range of symptoms that might be compatible with COVID-19. So our knowledge of patients who are positive and who have recovered will increase. So that information should be available.
I think the doctor who wrote in to tell me about that really wanted to know, do we have a plan to stop hospitals being unable to discharge patients in that situation? Because I think that is which is effectively a community plan. And I just wondered whether you...
So I think the answer to that is yes, but not if the implication is that we're going to be testing every single patient in hospital regardless of the symptoms that they're displaying. That is not what is currently proposed by Public Health England. But in terms of the additional financial flexibilities that have been set out in the budget, hospitals will now be able to, with their local authority partners, go and fund additional discharge support, and the emergency legislation that is before Parliament proposes to take out all of the delays associated with eligibility checking and needs assessments so that those transfers can take place very, very quickly. And we think on the back of that chair that potentially up to 15,000 of our 100,000 hospital beds could therefore be freed up for coronavirus admissions.
Thank you. Can I move on to ventilators?
Yep.
Now, obviously, lots of people with COVID-19 get breathing difficulties and need what's called a mechanical ventilator to effectively do their breathing for them, and that can absolutely be a matter of life and death. So what is the total number of mechanical ventilators that the NHS has access to in England?
As of today, we have 6,699 adult mechanical ventilators operational in the NHS, together with 750 paediatric mechanical ventilators, which can be repurposed, an estimated 691 in the private sector and 35 in the Ministry of Defence. So in the round, all told, we have 8,175. For some weeks now, we've been out preparing and procuring mechanical ventilators and can see a line of sight over the next several weeks to another 3,799, bringing the total to just under 12,000. And then in addition to that, you may have seen that the Prime Minister hosted a call with the manufacturing sector to seek to bring new supply into the country for mechanical ventilation, and we have set an open-ended goal for what that would be.
So just so we understand what you're up against, if we are not successful in suppressing the virus and we ended up in our reasonable worst case scenario, what does the modelling show you would actually need in that situation in terms of the number of mechanical ventilators?
Well, when you talk about the reasonable worst case scenario, if what you're talking about is an 81% infection rate across the population with none of the population mitigations in place that have already been announced, then there is no country in Europe that would be able to have a health service that could deal with all of that need, which is why it's so important that we don't get to 81% infection, and it's so important that these additional measures are enacted and succeed.
So if you take into account those additional measures, does the modelling show that when we get up to 12,000 mechanical ventilators, we should have enough?
That will partly depend on the clinical protocols that are being used for the patients that are requiring care, and Steve and Keith may want to comment on that. It will also partly depend, frankly, on the extent to which we, as the people of this country, respond to the asks that have been made of us. And it's very important that collectively we do, because that is what will keep the infection rate down.
But at the moment, I'm just really trying to get a sense. I understand that you can't predict these things, but I'm just trying to get a sense whether this is an issue that is potentially solvable. We could potentially have enough mechanical ventilators if yesterday's measures, you must have done some pretty detailed modelling of what yesterday's measures were.
Nothing is certain, particularly in an epidemic with a new virus where we are understanding the science better and better every day. But absolutely, our aim, working with the modellers that are working with SAGE and the various processes, is to ensure that we match our expanded capacity with the interventions that the government have announced, so that we have the best possible chance of having the capacity that will manage the number of patients who are infected with COVID-19, including mechanical ventilation. But as Simon has said, those measures will only work if the public act on them and the public stick to the various measures that the government have proposed. So this is important that we all do our bit in society, because the more we do our bit in society, the less demand there will be placed upon ventilators.
Yes, I mean, look, I understand you don't want to commit, but you're using phrases like, that will give us the best chance of having enough mechanical ventilators. I'm just really asking a very straightforward question. Does the modelling show what we expect to happen as a result of yesterday's announcement and the suppression of the disease, and what we expect to happen in terms of the additional new mechanical ventilators, perhaps getting up to 12,000? Does the modelling show that in that situation, if all goes according to plan, we could have enough?
It depends. I mean, I think we'll be in a better position to give you, based on what the group from Imperial and Sir Patrick Vallance, who's been speaking to you, what they are telling us, when we see the sort of impact that in practice over the next week, fortnight, 3 weeks, those measures are having. As we see the change, hopefully, in the new infection rate, the hospital admission rate, that will then give us more confidence as to what the landing zone here is going to be. But as we sit here today, less than 24 hours after those measures were announced, I think we all accept that there is a degree of uncertainty around how this will play out over the next month, 2 months, 3 months and beyond.
Okay. Then just a final area of questioning from me. I want to talk about protective equipment for staff. Obviously, it's a massive priority to keep staff safe, and indeed, we owe them no less, and of course everyone would agree on that. So if you look at the key elements of protective equipment like gowns, face masks, goggles, gloves, aprons, hazmat suits, do we have any shortages at the moment?
Okay, I think Amanda's going to...
Yes, thank you. So you're quite right. From a staff point of view, we know this is hugely important, and it is something people are rightly anxious about, because they want to keep themselves safe, they want to keep their family safe. So it's got, as you would expect, a very high degree of focus from us. I think on a kind of reassuring point, we have been assured that there is sufficient supply available nationally. So we've had the benefit, of course, of being able to release our influenza stockpile and also from the EU exit stockpile. So nationally, we are currently assured by colleagues that we do have the adequate supply we need. However, we are aware that there have been some local distribution problems, so we haven't necessarily got the kit in the right place. So what we've done today is set up a dedicated helpline so that if people have got local issues that they need immediate response to, they've got somewhere to go, and we can then make sure that the distribution is that the stock is being moved from where it is to where it needs to be. So this is something that's got kind of obviously a very high level of continual focus, but I think as we stand today, we have got the national supply that we require.
So I just want to ask this, and I might ask you just, Simon, just to respond to this, because I think staff will want to hear this. On the basis of what Amanda said, you are confident you will have enough protective equipment to keep staff safe. And if there are gaps at the moment, they're localised, but you will have enough to keep staff safe in the months ahead.
Well, I would just underline and endorse what Amanda has said, which is that as we sit here today, nationally, the Department of Health and Social Care procurement team have sufficient for the PPE that we're going to need over the coming weeks. But there is a distributional issue around the country, and we are going to need more of it. So let's just be clear, this is a challenge facing every country. A lot of the Chinese supply for some of the actually more basic items has been disrupted. So we are going to need to ramp up production for gowns in particular, some of the face masks, and that, given that this is not a flash in the pan, as we know, this is not something that is just going to be resolved in a fortnight or a month. This is going to, the coronavirus pandemic is going to be with us for months to come. We are going to have to ramp up domestic production on those items as well. So it's a combination of, have we got aggregate supply now? We are being advised yes. Do we need to improve the distribution to every part of the service? We think so, hence the approach that Amanda has set out. And will we need more of this stock over the coming months? Yes, we will.
Could I just read you a couple of comments that have been sent in from people on the front line, because there is such a lot of concern about this. This is from an A&E doctor who in London writing yesterday. So this doctor said, it's absolute carnage in A&E, utter chaos. We don't have any proper PPE. We've been given paper masks, not the gowns, not the FFP3 masks we need, and not everyone even gets those. Literally, the doctors seeing the sickest patients, the ones with suspected heart attacks, PE, sepsis, and all they have to protect themselves is a bit of paper across their mouth. I'm in shock. I feel like we're being thrown to the wolves here. Some of us are going to die. So how long is it going to take to sort out these localised problems?
So, I mean, first of all, clearly our staff are critical and they are doing an enormously important job, and we need to respect what they're saying. In terms of the PPE, as Amanda has said, establishment of a hotline to deal with the immediate issues of distribution so that hospitals where there are problems can contact us directly or contact the hotline directly to ensure that we get immediate supplies out to them. The PPE has changed in the guidance from Public Health England in recent days. So I think there is some education to go on as well about what is appropriate, depending on when the case is a confirmed case or a suspect case. And that is now an important part of what we have to do, is to educate our NHS staff as well, so that they do feel assured that what they've got is correct. We are in a unique position in the UK in that for two reasons. One is we have always held a pandemic influenza stockpile, and that is what the department is now drawing on and pulling that down and into that distribution chain, which is now happening. And that's something that's an enormous replenishing stockpile that we've had long term. As you know, many countries do not have that. We also, a silver lining, we inherited the EU exit stockpile, which again we managed to retain before a lot of that was taken down. So there is a significant amount there, but we do have to listen to the staff and we do have to respond and assure them that the personal protection equipment will get to them.
So the one thing that would reassure them most right now is if you gave me a date by when these localised distribution problems will be sorted out. I mean, can you commit that, for example, within the next week, all these localised distribution problems will be sorted out and the staff will have the protective equipment they need?
So we've had discussions this morning and we've been assured by the department that those stocks are there and a distribution model is going into place.
So a week?
So I was...
I think I would say, so I mean, they are being sorted out right now, but what we have also got in place today is an intention to do a kind of regional distribution so that then regions can make sure that they've got some control of additional stock that they can distribute locally. So in addition to sorting out through this dedicated line those individual issues that come up, we are putting some additional stock into the system so that regions can distribute it today so that they've got a bit more flexibility than they had yesterday.
But can that A&E doctor be confident that this time next week the problem will be sorted?
Well, I think what we're saying is we're not waiting a week.
So
we're
he
on
can
to
be.
this
Okay,
now,
if he can be, that's great.
and
That's what we want
that's the
to know.
intention.
So I just got one more, which he makes. This is a different doctor who makes a slightly different point. This is another A&E doctor from Luton and Dunstable. I'm treating patients who are perhaps presenting for a broken ankle and they suddenly start coughing all over you. You're breathing in an aerosol spray of droplets and we're not even wearing a mask, just scrubs and a plastic apron. So should the NHS, Sir Simon, nationally have a policy that all staff should be wearing PPE equipment in hospitals where there is a reasonable chance they're going to come in contact with a COVID-19 patient?
Well, I'll defer to Steve Powers, our National Medical Director, on that. We're guided by the advice that the infection control specialists at Public Health England issue, and that's the basis on which the PPE has been provided. But I think we all believe that actually staff do have a right to expect the sort of protection that would give them confidence. And so part of the question, the dialogue with PHE, is what is reasonable in A&E departments and other parts of the hospital. But Steve, I don't know.
Yeah, so I would absolutely agree with Simon. So clearly PHE are the experts in this area and issue the guidance. And as Keith has already said, that guidance has evolved over the last few weeks as we have learnt more about this virus. But equally, I think from our staff's point of view, providing them with the confidence that they are safe, as Amanda said, in all circumstances is important too. And so there is a continuous dialogue with colleagues at PHE as to setting the right approach, and I am sure that that will continue to evolve.
Just to underline the sort of national availability point, I mean, we have got right now, I'm advised, more than 28 million of the most intense face masks available, with many more in production. So those face masks are here in the country.
Thank you. And just a last question on PPE. Pulse magazine, this is for GPs. Pulse magazine had a story about GP surgeries in 20 areas being sent batches of masks which said best before 2016, and then a sticker had been put over those which said best before 2021. And a lot of GPs, and indeed the BMA, have written to us, are worried about the quality of protective gear that's being sent to them. Is there anything you can say to reassure them on that?
Definitely. Keith?
So those, we're fully aware of those. They came from one of the stocks that I talked about. They did go through a quality assurance check for health safety, and the reason they were rebadged is because that's what was appropriate. They were tested to ensure that they are of current standard.
Thank you. And then one last question for me, and then I'll hand over to my colleagues. And this is just really prompted by the absolutely heartbreaking scenes that people have been seeing in northern Italy. And the thing that perhaps the most awful stories you read are when doctors are having to choose which patient gets an intensive care bed and effectively play God, because the patient that doesn't get that bed is going to die. And there's a lot of people who have been writing in saying that they don't have guidance as to how to make those appallingly difficult decisions. Is there a plan to send out guidance, particularly to intensivists, but to all doctors, so that in that nightmare situation where you have to make those choices, doctors have actually got some guidance that they can use?
So the first thing I'd say is that reason that we are expanding capacity, and the reason that we have been working with government closely on the policies that they have introduced and discussing policies which they may introduce, which they have laid out, is to ensure that we do everything that we possibly can not to get into that circumstance. Because doctors make clinical decisions with patients, with relatives every day. And what we want to be able to do is to support doctors to make those continued decisions on the basis that they are currently making them. And because we are ahead of Italy in terms of the curve of the epidemic, as I'm sure you will have discussed with Sir Patrick, that gives us the opportunity to do that planning ahead. But of course, nothing is certain in medicine, and doctors do, and clinical staff have to make a difficult decision. And of course, if that becomes the case, then we will support them locally and nationally in that sort of decision making. But I must emphasise that if everybody in the population follows the guidance that's been given, and we work on the capacity in the way that we have described, our aim is to ensure that medical practice does not have to change.
I understand that, and I think we'd all agree with that. But I just want to very specifically ask you, are you going to be sending out guidance to intensive care doctors that tells them how they should make such impossible decisions if they end up having to make them? Is that guidance going out, and if so, by when? Because that is on people's minds.
So I would say that we would be working with our relevant colleagues in intensive care, but not just in intensive care.
So you may not be sending out that guidance.
Well, I think we have to work out the best way of doing that, but I absolutely hear the concern, and it is something that we will be working with our professional colleagues in intensive care and other specialties to address.
Okay, you can't give any more comfort than that, because these are, this is happening today in Lombardy.
Yes,
and people are worried it's going to happen here, and they just want a very simple set of instructions, guidance, that's all. And I think that you're basically saying we'll listen to you, and we understand this is difficult.
No, I'm not saying we'll listen. I'm saying that we want to work collectively and collaboratively with our colleagues, rather than send out guidance. This is something that we need to do.
Okay, but you will come up with some guidance. It might not be you that have written it, but you'll come up with some guidance, talking to the Royal Colleges and whoever. Is that what you're saying?
It's an if, and as I absolutely emphasise, that is a point that we do not wish to get to. But of course, we will work collectively on guidance where it is required.
So there would be guidance before such situations arose?
If, and it's a huge if, yes, we will work on that guidance.
Thank you. Luke.
Thank you for all coming in today. And just before I came in the House, I'm a GP by background, so my questions are set is just about some of the practicalities that you might see. And if I could start with secondary care and just work my way out of hospital, if that's okay. You mentioned 8,000 ventilators. How many of them are in use at the moment?
Well, a number of them are in use for some of the procedures that we're going to defer. So part of the reason for calling a halt to non-urgent operating is that we not only will free up ventilators, but also critically a number of the operating theatres and recovery rooms, which can then be repurposed for extensions to critical care.
So you don't know if it's 5,000 are in use at the moment, because once a patient's got a ventilator, that's it, they've got a ventilator. Do you know the number in play at the moment actually being used?
Well, a number of these are going to be brought back online rather than being in use right now. And we've also got to work. I mean, I think you know this, but it's worth just saying, it's maybe worth Steve saying, that mechanical ventilation is not just a question of a bit of kit. I mean, it's actually a very complex and sophisticated procedure that involves a sedated, paralysed person, perhaps for 10 days, carefully being monitored. So it is about trained staff as much as it is about equipment.
You beat me to my next question.
So I think Simon gave you the number of ITU beds.
Yeah.
And of course, not everybody in an ITU bed is mechanically ventilated, and that will be changing literally from hour to hour across the NHS. So it's an answer that changes on clinical need every minute. But a proportion of patients on those ITU beds absolutely will be on mechanical ventilators. As Simon's also said, there are mechanical ventilators used in operations, in operating theatres, and again, that number varies from day to day. So I think the key number is the number that he gave you earlier, which is the number of ventilators that are available, because our capacity planning assumes that they will all be used.
So on that, can I come back on that? Because with that, you rightly point out, how many staff do you have to use it? I couldn't use a ventilator. I could probably be trained, but it would take a while to get used to it. The other thing that goes with it is arterial blood gas machines.
Yep.
They're critical for working out what settings you need. Have we got enough of them aligned with the ventilators? So the people to use it and the machines to make the judgment and adjustments.
Well, we've been obviously talking with the Intensive Care Society, the Royal College of Anaesthetists, and many of the other medical disciplines. As we have a slowdown in non-urgent surgery, a number of anaesthetists will, with their intensivist colleagues, be available for this type of work. But, I mean, I have sat next to me a professor of medicine and a trauma surgeon, so why don't I hand over to Steve and Keith?
So again, Simon is absolutely right that there are staff that use ventilators, but not in a ITU capacity. They will clearly need some further education, some retraining if it's a skill that they had in the intensive care setting they haven't had before, and we are working, as I think you've heard, on ensuring that education is in place, and I know many hospitals are doing that already. On your other point about other bits of kit, and it's not just kit, it's drugs, etc., that are required for patients who are ventilated, then we are also looking at supply chains and ensuring that we have the supplies in place for everything else that is required around ventilation. And the final point I'd make is that there are forms of ventilation that don't require mechanical ventilation connected to a machine, so non-invasive ventilation with a tight-fitting mask. Now, we think actually, from the experience that we have heard about in other countries, that the clinical course of this disease is such that we want to place an emphasis on mechanical ventilation. And that is exactly why, as you've heard, our efforts are aimed at increasing the supply and number of mechanical ventilators. But that does not mean that other forms of oxygen treatment, non-invasive ventilation with a tight-fitting mask, or for actually probably the majority of patients who are hospitalised, just regular oxygen is not an important part of the treatment as well. So that is why we are working to ensure that we have supply of those items as well, and why we're working hard to, for example, to ensure that the oxygen supply to hospitals is maximised so that we don't have a constraint in any part of the supply chain.
Fantastic.
Keith might be.
Can I just add on that? So obviously there's the medical side in terms of the anaesthetists and the intensive care doctors, but I mean a critical part of this is the anaesthetic nursing staff and the operating department practitioners, who we know, as they are all occupied in operating theatres doing planned work a lot of the time. As we wind down that activity, then they become available, and the ventilation, breathing support that's required for patients' coronavirus is a relatively, and I say relatively because it clearly is specialist, but it's a relatively easy end of the very complex things that go on in intensive care, which will include renal dialysis and lots of other things which are important. So it is therefore possible to be able to look at your resource, your staffing resource quite differently, and to be able to support that across a wider number of patients. So it's all about this. And so what we are doing in the NHS over the course of this week, which started today, is we are doing an exercise with all our acute trusts, and essentially walking them through an exercise to get them to think and understand. Now, many of them have done it already, and that's fantastic, and you can imagine that most doctors and most hospitals are way ahead of this. But to make sure everybody understands what these pressures may feel like and how they best adapt to ensure that as many patients as possible get exactly the right care we want to give them, we are walking them through. So today we're giving them a point in time in that curve, week 6. Tomorrow we give them what's called an inject. We give them a lot of new data that says, now you're at week 7. On Thursday we'll take them to week 8, and on Friday week 9. Now that will stress the NHS on a tabletop, safe, completely useful exercise so that they understand what they're going to have to do. Now, some of them will have their plans in place and can test out their plans. Others will realise their plans need to do more, and they need to think much more creatively and innovatively about how they will move towards the sort of bed numbers and the sort of mechanical ventilations and the sites that they can provide that over that period of time. Tied into that is going to be an education programme. There's a bit of a call to arms as well, call to action, so that the NHS is all on the same page in terms of responding to this, because we do need all the NHS to move with us, and we need all our supporting partners outside of health to help us on this. So there will be education packages which will not only ensure that the staff have the education, they really understand about what a coronavirus is. We take an assumption that everybody in health does know what a virus is, but actually if people aren't working in that field, they are unsure, and that's some of the anxiety that, Chair, you alluded to, is this lack of familiarity with this because they don't see it. So the education programmes going through, some of which will be nationally based, but in terms of national resource, and many will be locally based as to how each of the hospital specialties, and you're talking about secondary care, how as we walk into this and as we expect it will become more difficult, how they take down the things that they would normally do that have the least impact on patients, perhaps those things that just cause inconvenience and not harm, take those things down and then redeploy the staff. So, for instance, I'm a trauma surgeon, but in the emergency department, there are many injured minor patients you may well have sent in previously who have injured toes, fingers, ankle sprains, whatever. We can lift all of those out of the emergency department and move them into the orthopaedic setting and free up our emergency doctors to do the respiratory cases and the other ones which only they can do. And we can do that through each specialty so that we can start to completely restructure the way we deliver care.
With some of that then, the next step down would be routine care cancelled operations. People with cancer, can you just comment, cancer operations, will they still go ahead?
Yes.
Yeah, thank you. Prescribing rules for GPs, we're a bit further out now. Will there be any relaxation around prescribing rules, repeats, when people should have reviews to try and relieve some of the system a little bit lower down?
Almost certainly, yes.
Okay. New registration of patients and indeed staff. Patients have to come into a GP surgery to register. Plenty of people will now start be thinking, I need to get onto a GP healthcare. Normally they have to come in and show identification. Just wonder if there's any thought behind doing something about that or online. And also for staff who want to come back in, is there any centralised system for allowing staff to get up to speed very quickly to step back into giving care?
So I think it's a probable yes and a yes. In terms of the probable yes, perhaps I can just sort of put a bit of context around that. What we're doing, not just with GPs, but we're going to do the same with community pharmacists, we're going to do the same with hospitals and NHS trusts, is essentially say, look, for the next 4 to 6 months, clearly we are all going to be going flat out at coronavirus, and therefore we are suspending the usual rules around contracts and payments and incentives, and just paying upfront the funding that staff and organisations need in order to do the right thing for their patients on coronavirus. And there will be many myriad aspects of the way the GP contract works that will conform to that, but it's not just GPs, it's all parts of the health service as a whole. And in the letter that I've issued to the NHS this afternoon, I lay that out.
That's really, can I pick up on that then as well? Because CQC have said they're going to reduce their regular checks in essence. One of the big things that happened last week was the primary care networks and a vote by the LMC to vote it down. That's due to come in. I wonder if there's any thoughts. The benefit of reducing it is not putting it through. May well be the fact that you've going to reduce the workload. The downside is there's money attached to it. So I just wondered, is there any thought process about these kind of processes being elongated, postponed, and the impact that might have?
Well, my team are obviously discussing with the General Practitioners Committee the best way of doing this going into next year. But two of the things you've just referred to, frankly, will be a help to practices, not a hindrance, namely being able to work together with other practices in their neighbourhood, also known as primary care networks, and getting extra staff in, whether it's therapists or nurses or other members of the practice team. So those are probably two of the things that you wouldn't want to go slow on. You probably want to do more of those at this highly pressurised time.
Thank you.
Paul.
Hi, thank you very much, all four of you, for coming to speak to us today. Just following up on a couple of things that was said in response to Luke's questions. So you've talked about suspending or postponing non-elective procedures in the NHS, and you also talked about cancer kind of procedures as well. I just want, forgive me if this has been mentioned all the way, I just want clarity. How are trusts still going to be measured against existing targets, such as the 4-hour waiting time in A&E, or are those going to be relaxed for the duration of this pandemic?
So there are no changes going to be made to the measurement set, but the reality is that we are asking the whole of the NHS to mobilise around doing the right thing under this pandemic coronavirus outbreak, and of course ensuring that patients are looked after appropriately and quickly in A&Es is an element of that, but this is about doing the right thing and applying the correct local judgments in a flexible and agile way.
Okay, well, I think that's the key word, isn't it? Flexible. You don't want to see NHS trusts make it, well, you don't want to see the unintended consequences of previous targets that in peacetime, if you like, made absolute sense, but in this time make no sense whatsoever.
Completely agree.
Okay, all right. I just want to move on to, again, building on some of the things that Luke said about the capability of primary care and community care. Are you confident that general practice have the capability and the resource to deal with the effects of this pandemic, but based on the modelling that already exists?
So I'm confident that general practice, like hospital practice, as Keith has outlined, will need to change the way that they are working over the next 4 to 6 months, because we have an unprecedented situation that will require that. Part of that, as again Luke asked and Simon replied, will be discontinuing a range of things in order to change that model, but some of it will absolutely be working in a different way. So I expect they will still be supporting their patients that they know, and after all, for instance, the vulnerable patients who are being asked to spend more time at home and to spend more time being shielded, these are the patients that actually GPs know the best, and I'm sure any GP would immediately, probably without going to their list, give a list of those patients that they were most concerned about. But they will have to support them in a different way. So that might involve more telephone conversations. It might involve more remote ways of contacting rather than people coming into the surgery. So I think this will absolutely force a different way of thinking, but I'm absolutely confident that practices are up to doing that, and actually many of them use models that I think are perfectly applicable to the situation that we are going to go into, and will be well used to the sorts of changes they need to make, although in an unprecedented time that those changes will have to go further than they might do normally.
Okay, so forgive me for just building upon this, just painting a scenario. So if you've got a patient with a particular long-term condition like diabetes or AF, and they're having problems managing their condition, and they're very used to already kind of going into their GP on a regular basis and having that personal relationship. I know already in some GP settings, it's the case that you have to be on the phone at 7 o'clock in the morning to get an appointment and all the rest of it. How do you think that modelling would look like? Is it going to be very much more telephone kind of?
Yes, absolutely.
It must be. It must be. I mean, we need, particularly the patients you described who are vulnerable and they have underlying chronic conditions. Okay. They are the ones that we, as the government programme has been laid out, those are the ones that we do need to either increase their social distancing so that they don't get the exposure to the virus. And secondly, for those that are very vulnerable, and we will be saying more about that as they're defined in the coming days, then we will essentially be asking them to stay at home to protect themselves. So whereas at the beginning of this, and this is how fast it's changed, it was only 6 weeks ago that WHO said something to the tune of, it did not yet constitute a public emergency. There's no evidence to spread outside China. That was the 23rd of January.
Yeah.
Can you see where we've gone since then? We've had the repatriation flights. We've completely changed the model. We've been isolating people who had the virus in order to protect the rest of the society from acquiring that virus. We're now going to a position where we recognise there are vulnerable people who we need to protect, isolate them, to protect them, to make sure they don't get the virus. And so this is a substantial shift. And those sort of patients, that's where general practice will need to transform significantly. So CCGs have been given permission to ensure that the finances do not interfere with the way that the practices can adapt and change. So it is about video conferencing, it is about telephone consultations, it is about increased out-of-hours services so that if people need home visits, that can be arranged. So this is quite a transformational model. I suspect at the end of this, when we all sit down in a year's time, we'll have learned some really important things about traditional practice that will benefit the NHS and benefit our patients, and at the same time we'll have protected a lot more vulnerable patients.
And I think you said flexibility and agility, and that's absolutely the mindset that all of us will have to be in.
Because I'm thinking about people, if I may, like my mother and my father, who are used to that trip to the GP almost sometimes on a monthly, fortnightly basis just to manage their long-term conditions. Let's just get the message loud and clear. We're saying do not go to a primary care setting because this is a substantial change, as you've said. I mean, what are you actually doing to, other than the daily, which I think is very useful, the daily briefing that you see the Prime Minister having in every day about the change in the situation, what more is the NHS doing to provide that sort of essential and accurate information, not only to the public, but to NHS professionals too?
In terms of direct public communication, so on the NHS.uk website and the NHS Online website, there is the full information set, including the advice that came out last night from Public Health England on social isolation. And over the course of the next week, as you just heard, there will be specific contact made with the majority of people who are in the very high-risk group, who are particularly being asked to reduce their social contact and shield themselves from those other interactions so that they can have their questions answered about, I have an appointment scheduled for the hospital, or I need to be in touch with a GP. What are you recommending I do about that?
And what do you think we're doing? I mean, I've got experience of this already in my constituency and in my patch. I mean, what are we doing to counter misinformation that's already kind of out there in the public domain?
So we and the Department of Health and Social Care have been, and in fact the Department of and DCMS have been working with the social media companies, including Google, Facebook, and others, to try and ensure that where ludicrous lies are promulgated online around treatments that most obviously won't work and are just a public scam. And I include, frankly, in this some of the homeopathic practitioners, but there are others as well, that is zapped by the platforms who are providing access to that damaging and scurrilous material.
And NHS.uk is the public point of truth. So if people need to go to find out what the position is, that's where they should go.
Okay, that's very reassuring. Just something very reassuring on a personal level. I mean, I've seen that there has been information provided to, or there's certainly been an announcement around pregnant people who are pregnant and how they should look after themselves. Is there going to be any specific information to young mothers of recently born babies? I say that as father of a very small baby.
When it comes to pregnancy, the evidence base in this virus is fairly limited at the moment because obviously it's a new virus and we have emerging information. But working with the Chief Medical Officer, we are urgently looking at that evidence base, and we will be issuing further guidance specifically around pregnancy and the period of pregnancy where we believe most care needs to be taken.
I'll just add to that, obviously we represent NHS England, but all of the activity is being done across the four nations at every level, between the NHSs and across the Chief Medical Officers, and the Chief Medical Officer of Scotland is an expert in the area of pregnancy.
And Chair, just one last question, if I may. And forgive me if you're not the right audience for this. It's just I had a phone call this morning with the chief executive of the Sue Ryder hospices, and I'm just interested to know what sort of implications you've thought, what implications of the impact on coronavirus on, I suppose, the hospice sector could be for the NHS. For example, if they struggle to cope and they're beginning to say they can't take new patients for one reason or another, have you thought about how
So
that
I think
might
Hospices UK have raised this question with the Department of Health, and I know that the Department of Health are looking very carefully at whether or not additional support could be provided to hospices during this very difficult time.
Okay, that's very reassuring. Thank you.
Thank you. Dean.
Thank you. May I echo the comments earlier? Really heartfelt thanks to every member of the NHS and their families as well, who no doubt are supporting them. My questions are really around volunteering in the community. I had emails from people who volunteer with the St John's Ambulance, for example, and they're asking, what is the approach around deployment and training for people who've got a certain level of skill and understanding, so that they can then support on minor injuries or minor ailments, so that they can take the pressure off on that side of things.
Yeah. Sorry, did you say St John's Ambulance in particular?
St John's Ambulance was an example, but I'm thinking also, pharmacists, perhaps even school nurses over time as well. So anyone who's got skills who could support you.
Yes. Well, St John's Ambulance are very kindly working up a proposal specifically to offer additional support in emergency departments, which I think is based on a pilot which they've successfully undertaken in Peterborough with trained volunteers who've been helped with recording observations and supporting paramedics and so forth. So I think they are planning a call to action to bring more volunteers to upskill people as advanced first aiders over the next several months. And many of these volunteers, in fact, are student paramedics or nurses or doctors who could help, but it goes wider than that. We've got 10,000 community first responders across the country who already volunteer for NHS ambulance services. So we are very grateful for the work that St John's Ambulance will be leading, but also Age UK and a number of other organisations too. And that's going to have to be an enormous part of looking after speaking personally, my parents' generation as they go through what is going to be a very difficult number of months.
Yeah. And with regards to that, because we're seeing lots of volunteer groups popping up all over the country. In my area in Watford, we've got many appearing Facebook groups, all sorts, gathering data of where vulnerable people are and so on. And one of the things that seems consistent is that the fact it's so inconsistent is the consistency. You've got lots of groups really wanting to try and help. And I wondered, with regards to that volunteer networks, especially within this space, is there a sense that there will be a centralised database so people who want to help can go to one place and they can potentially be vetted if needed, so that we don't end up with the risk of A, the wrong advice being given, but B, so that they know that, a bit like the NHS website, they go to one point of truth, as it were, in terms of supporting?
Yes. So those that are doing volunteering, particularly in the sort of health settings or health related, and the British Red Cross obviously is another fantastic example of that, we absolutely do want to do that. But as you say, there are many local groups for which actually the right network will be through the local council, the local government association as the umbrella for local authorities, I think is going to support the Ministry of MHCLG on putting in place that kind of infrastructure, because obviously what happens in Watford might be different than what happens in Surrey or what happens in Doncaster, and so that localism is also very important to foster as well.
And with regards to that as well, it was talked a little bit earlier, mentioned earlier around care homes and so on. What's the pathways at the moment? I met with a care home in my patch this week, and they were very conscious that, especially people with complex issues that are in hospital at the moment, it's not just the case that they need to shift beds into another location. There's a lot more to that. And how's that planning going at the moment? And what do they need to do to support you, and vice versa? What are your plans to make sure that they have the right information and advice?
So there's a variety of things going on with the care homes. So I think there's the staff side of it. which is clearly important in terms of how the volunteer sector comes alongside that to support, because we will have numerous patients now at home because of the programme that's coming through government. And so we are looking at all of those and we have the local resilience forum as part of the emergency planning structure within the NHS. So there will be collective efforts at the local level to identify the sort of support that's needed across all of the community. And I think care homes actually are in a privileged position because they exist and they're a stable structure, and clearly they want to protect. There's like a collective that we are protecting, isolating for their own benefit. So that will be a key for the care homes. For my concern is actually the wider number of people who now will be isolating at home for what is really quite a lengthy period of time. Now, some of those the local authorities will know well. They'll be already receiving social care support, and that's wonderful. But clearly we need to look at the social care workforce and ensure that we're supporting them. And so part of what we're doing is not just, although the Department of Health and Social Care is responsible for the social care part, we are clearly aligning on the sort of work we do with them. There will also be those people who have friends and family who can support them individually at home, and that will be absolutely paramount. And this is where we need, as Simon said earlier, the whole of the country has got to stand up behind this. This isn't something the NHS can do on its own, and not something the local authority can do on its own. But then there will be those people who we will identify in society who actually may have had social isolation before we started. Mm-hmm. Loneliness is one of the things we've discussed around this table before. And here is another opportunity for us to use our wider support in society to pick up some of those problems. And this is everything about everybody doing the right thing. Everyone needs to. We've said the message is, it's being responsible as an individual and being responsible for society. Easy to say, hard to do. But simply, washing your hands could be one less patient on a ventilator. And I think we've got to people need to understand exactly where we need to be as a nation on this.
With regards to that, thank you, it's a very thorough answer. In terms of that though, do we think at the moment the social care sector is equipped enough in terms of size and scope and funding to be able to cope with this? Because I'm thinking of, older patients or people who might be bedridden, who have to be moved regularly to get rid of bed sores and things. So are we
So I'd have to say that's obviously a responsibility for the department.
Yes.
Doesn't sit with us. But we are doing everything in alignment. And I have to say, having sat around this table from an EU exit point of view before, there's an immense benefit from the no-deal planning into adult social care. Because they started to collect data, understood the bed availability, looked at their resilience, started to understand just how fragmented they are. 12,500 care homes. We've got more domiciliary care providers than we have GP practices. So them pulling all of that together to understand what was needed has put us in a much stronger position. And that additional window we've had from the contact tracing and the excellent work Public Health England have done has put us in a position where we can walk into this with more confidence that we understand it, but clearly we have to deal with the hand that is dealt to us.
Thank you.
Just maybe put a slight sort of addition to what Keith has said, and I agree with everything he has said. The fact is, however, that the social care sector, as we know, has been under enormous pressure for a long time. And so going into this pandemic, we have got to take the opportunity to do what we can to support and strengthen social care, because without that, apart from everything else, not only in terms of supporting the millions of people at home who are shielding from social contact, but apart from anything else, in terms of being able to free up the 15,000 or so hospital beds that we need to be able to discharge people from so that we can receive coronavirus patients, that will be very difficult if social care is not able to also play its full part.
And so just a few questions now on the staffing side of things. First of all, in terms of, there will be, naturally, and there already are, no doubt, GPs or nurses and so on who will be self-isolating. Are there any plans to say, instead of being stuck at home twiddling your thumbs, although I'm sure they could do with the time off, are there opportunities for them to take the place of perhaps doing remote surgeries, not as in physical surgeries, but remote consultations with patients? Because that no doubt will take the pressure off those who aren't self-isolating.
Absolutely.
Yeah. I mean, yes, absolutely. I mean, one of the things that we are asking people to do locally is work with staff also who are in those highly vulnerable groups, so that we can make sure that they have the opportunity to make a contribution, but from the safety of their own homes. Mm-hmm. So that's a sort of similar idea as anyone who, and we know, by the way, of course, that NHS staff are desperate to make a contribution and, you know, are going to want to be able to do that, whether they are basically well at home because they're self-isolating or because they are in that higher risk group, and therefore for their own safety we need to make sure that they are able to work from home but contribute differently. So those are exactly the sorts of conversations that we know are happening now across the NHS.
And is the technology infrastructure there for that? One of the reasons why I ask is that one of the barriers, saying that the commercial world, is things like GDPR around data privacy. But do you foresee a point where patient privacy might need to be managed slightly differently to ensure patients are being looked after?
We're confident that there is the flexibility consistent with patient confidentiality to make this work, and our team at NHS X, who do our digital work, have paired up with the Information Commissioner's Office and have issued, the ICO has issued very helpful, straightforward guidance saying there is nothing about the way the rules work that should stand in the way of this flexible way of looking after patients.
And with regards staff who are self-isolating, obviously that's one challenge. But the other is, you know, we've talked a lot this in the previous session around school closures. The reality is, in a couple of weeks' time, schools will be closed for Easter, or three or 4 weeks' time, and then again in the summer. Are there plans within the NHS to set up some sort of childcare network so that nurses and doctors don't have to stay at home with their kids? Because that's going to happen. They may already have booked holidays to do that. What's the thinking and the planning around that?
Well, I think it's an interesting idea. We are obviously thinking about all scenarios in respect of schools. You know, it's worth remembering that we have a workforce, many of whom are certainly, well, on this side of the table anyway, still with school-aged children. Don't know about you chaps. So yes, we experience exactly what you're describing. That is clearly something we should look at. But more broadly, obviously the interaction between schools policy and staff availability in the NHS is a big consideration.
Yeah. And with regards staff looking after them longer term, is there a plan? And I appreciate we're in really intense times right now in terms of just getting over the bump, as it were, but around mental health and support for them, because they are going to have to, as the Chair mentioned earlier, make very difficult decisions. They're going to see things that in some cases might feel akin to a war in terms of the volume and intensity. What's the thinking on that, and what's the plans for that, please?
So couldn't agree more. I should have said, actually, before I did this job, I was the Chief Executive of Guy's and St Thomas's. So the absolute reality of how it feels when you are kind of on the front line providing care is something that I guess is sort of, we're all very conscious of. And people are doing an unbelievably good job, as you know, before coronavirus, let alone now. As colleagues have said, I mean, all of the actions we're taking are designed, of course, to prevent us getting to that position where people feel under that degree of pressure. But nonetheless, even now, you know, we would all recognise, I think, that we need to support staff however we can. So particular consideration around mental health, certainly. So we have plans already being developed, and we're already in active conversation with the NHS about what we can do locally to support people. But I want to add to it.
Thank you.
Laura.
Thank you. I want to ask a few questions about the residual bit of the NHS, which won't be dealing with coronavirus. Can you talk through what the infection control is in hospitals? People with elderly relatives in hospitals at the moment will be very worried. Can you reassure them on that point?
Right, so the programme that we've already put in place is that patients coming into hospital who have symptoms that are consistent with coronavirus, although most at this point in time probably don't have coronavirus. A few weeks down the line, it may be different. So those patients are being tested, and we are managing them currently in a way that is a form of isolation, but it's not like you put them in a side room whilst we await the results. So that protects other staff. And I think people need to understand what coronavirus is. So that being too simplistic, but a virus is a tiny, tiny bit of genetic material. It's minute. I mean, you have millions of bacteria on your hands, but as far as a bacteria is concerned, a virus is a bit like a mosquito on its skin. That's how small a virus is. And what a virus does is it attaches to your cells, usually in the nose and throat and lungs. That genetic material goes inside the cell. Unless you've never seen that virus before, you don't even try to stop it. The virus then takes over the production line in your cell and produces thousands and thousands more virus until the point when it releases them. And that's when you get the cough, the temperature, because you've now got a damaged cell and your body recognises it and starts to attack. So that's what's going on. So we understand what the virus is, but it also means the virus can't go anywhere. It doesn't float around in the air. It comes out on the droplets when you cough. And those droplets will only go a certain distance. So we know, and hence the 2 metre that we talk about in terms of social isolation, if you're outside that, you're not going to get the virus. But what it means is in a hospital, that's what we have to do. And that's why the level of personal protection equipment that we now, or Public Health England now recommend, is different from what we started. When we started, we called this a high consequences infectious disease. But it wasn't a high consequence for most individuals, because for most individuals, this is nothing worse than winter cold. It was a high consequence for society because there's no immunity and we didn't know what the virus was. Now we've learned a lot more about the virus. We understand, and actually we can treat it pretty much like flu. It's not flu, but we can treat it pretty much like flu. So going back to your question, sorry for that deviation, but I thought it might be useful. In terms of back to your question, what that means is when a patient comes into hospital and we've tested them, we will get the result back on whether they're positive or negative. If they're positive, we are moving those patients into cohorted areas. In other words, we put them all together in the same area and nurse them in one area. That's important because it makes nursing much easier because you can treat them all in the same isolation area, if you like, rather than having to go in and out and the multiple changes and donning and doffing of all that equipment, which is arduous and also uses up a lot of equipment. And we've discussed what the supply chain is like for that. For the other patients that go into hospital, then we can be confident that they haven't got coronavirus. Now, we can't be absolutely certain, and there's never, as Steve said, there's never a certainty that we've got everything right. But in general, what it means is that we will be able to have segregations of pathways of care through a hospital to give that assurance. And it also means, in terms of going back to the staff point that Amanda was making, it is possible for us to take staff who we may consider that we don't want, perhaps the pregnant member of staff, and we can move them to an area where the likelihood of exposure is much, much, much lower. So there are lots of opportunities, and that's what today in this directive that's gone out to the NHS, one of the early things we talk about is those segregated pathways and therefore the appropriate protection of both other patients and staff. Now, the visitors bit, somebody else may want to comment on what we think should be happening with visitors, but that is an important thing in its own right.
And are you confident that you can maintain that segregation as we reach the peak of this illness in this country?
So we will, what we're asking with the exercise that we're going through, as I've said, taking stress testing each of the services over this week, is that it will become apparent how many patients you need to cohort and how you go about doing that. So you would imagine that an organisation, and each will be different and its estate will be different, but it will work out the sequence of wards that are best placed to become the cohorted wards for patients with coronavirus. In addition, the things like you will think about segregating your emergency department in a way that best fits the layout, so that patients who come in with symptoms that are consistent would be in one area rather than another. Again, maximising segregation. Likewise, when they go down to have diagnostics, CT scan of the chest, for instance, is a common investigation in COVID-19 disease. In those circumstances, you might start to segregate if you have more than one, or because that would reduce your necessity for the amount of decontamination that needs to go on that follows the patients around a hospital. So this is the sort of practical things that we need to do and maintain for as long as we possibly can to protect our patients, our staff. But clearly, when it comes to visitors, there is a logic in not exposing visitors to that environment and not bringing visitors in who may bring a virus into an environment that hasn't already got the virus.
So just to add to that then, at the height of the epidemic here, it is likely that every NHS hospital will be looking after coronavirus patients. and it is possible that some hospitals will almost exclusively be looking after coronavirus patients.
Right.
So as we've looked at what the respiratory and oxygen capabilities look like in different parts of the NHS estate, there are some places where, frankly, we may choose to deploy almost the entirety of the hospital for coronavirus patients. And then just finally on the visitors point, we're issuing new guidance to hospitals recommending essentially a very significant reduction, other than in the most essential circumstances, of routine visits to hospital patients.
Understood. And just in the case that you describe, where we're at the peak and there may be hospitals which you deem are dealing almost entirely with coronavirus, if you are, for example, a stroke victim in an ambulance, will that mean you'll be diverted elsewhere?
Yes.
Yes, right, fine. And then also, if, for example, you are a pregnant woman going into labour and there is a complication, you urgently need to go to hospital, again, will that mean that that woman is diverted elsewhere?
It could do, although it is less likely that some of the maternity wings would be converted to
right.
looking after the respiratory needs for coronavirus patients, so they would need to be completely separated from an infection control basis.
Understood. And can I just clarify the point about the spread of the disease, just in terms of if you are asymptomatic, can you spread this disease or not? I just think it's helpful because there seems to be some mixed messaging around that.
So I think the evidence is that you are you spread the disease when you develop symptoms. It is possibly the case that there are asymptomatic individuals, and one of the uncertainties is around how they spread. But I think in general, the spread of the virus is from symptomatic individuals to the point in the first few days of symptoms, and then it tails off quite dramatically as they get asymptomatic. But we are learning about this all the time,
right.
And I think it would be fair to say that the evidence is still evolving.
What I would say to that is, so the earliest sign that you have symptoms that be consistent with coronavirus, you get out of work, you go and socially isolate, and you self-isolate. Because it's not, you don't wait around till tomorrow to see if this is going to get better, because you are now highly infectious. So earliest signs, even mild, you go and self-isolate to protect others.
And the 7-day isolation policy is designed to take you through the period where you are most infectious to a period where you are not infectious. And then you can go back into society.
And I think then it sort of also explains what self-isolation is, because I think a lot of people don't quite understand that. If you're clearly you're in a house where you can sort of segregate yourself, and perhaps if you're fortunate to have a second bathroom or you can do that, then this is staying away from everybody else, that you are using your own towel if you share a bathroom, you're washing down the sink afterwards, you are sleeping on your own, you don't share anything, and surfaces that you may touch. So apart from the droplets, which is the main form of spread, what are called fomites, as we call in the medical profession, things you touch. So things that you touch and you drop the virus on, particularly if you've coughed into your hands, when you touch those surfaces, the virus will be viable, should we say, on that surface for a period of hours. And so somebody else touching it, coming along, would then pick up the virus. And if you do what we all do, which is touch your face repeatedly, you will then be at risk. So it's there. It's washing your hands for the 20 seconds is absolutely critical, because whether it's the tube train you've been on, whether it's somebody else's car you've got out of, whether it's touching a shelf in a supermarket, washing your hands just frequently is the single most important thing to do. So that's what self-isolation is about. So wiping down the door handles, you just don't have anything that you've touched other people can touch until you've gone through that 7-day period.
And of course, the reason that you are most infectious when you have symptoms is exactly because of what Keith has described earlier, is that the spread of the virus occurs in droplets that you cough, and cough is the main symptom. So it's that symptomatic period that is the key, and that's where you need to stay at home, as isolated yourself as much as possible from everybody else, because that is the period where you are shedding virus and potentially spreading it.
Thank you.
Thank you. I've just got a couple of questions from colleagues who aren't able to be here. So first, this is from James Murray. So he's just a question about information provision. Are we confident that the information provided on 111 and the NHS website is always up to date and broad enough?
So the answer to that is we tried very hard. I have to say, going forward, things will be much easier because we have reached a sort of a tipping point, and now we have quite a stable run into the next phase, although it will evolve and there will be differences. But as I said, it was only 23rd of January when this was still considered not to be significant, and the policy and changes have happened literally every few days, and it was almost impossible to keep everything aligned. Going forward, we've had an enormous amount of work gone into the NHS 111, particularly the online service. It's gone from sort of not really existing for coronavirus to taking 650,000 hits a day.
Right.
And the information on there is, we guarantee, updated every day it needs to be.
And could I pay tribute to the staff who man 111 and who run 111, because they have seen unprecedented demand and have also had to change what they do very, very dramatically over a very short period of time. Not just because of the demand, but because of the evolving nature of the disease and therefore the advice that they have been asked to give. And they have done a huge amount of work under extreme pressure to ensure that the public have the information that they need.
Thank you. Second question from James. Do you think the new guidelines issued yesterday to the public about social distancing would be more effective if they were mandatory rather than advisory?
Well, I think we will know the answer to that question within a matter of days. And as I think we heard the Prime Minister say yesterday, obviously the first approach is to appeal to the good judgment and altruistic instinct of the British people. But if it turns out that further measures are required, then I'm sure the scientific advisors will put those before the government to consider.
And could I take that back to the question you asked at the start, Chair, around the modelling? Because I think what is really important is the actuality of what happens now. And Simon's point around how the public respond to these measures, as I said earlier, is really critical. So what we need to see in the next few days, in the next week, is evidence that they are having the effect that is included in the modeller's work. And I think the answer to the question that you've just asked, as Simon said, is very much contingent upon what we see. But I can't be plainer than to say the importance of adhering to these measures as much as you possibly can is going to make the difference to whether the NHS copes or not. It's as plain as that.
Thank you. And a question from Rosie Cooper. What message or advice would you have for dentists who are obviously not able to do their work remotely and haven't been talked about virtually at all in the national media, and just wondered if there's anything in specific that you would want to pass on to them?
Well, I think the Chief Dental Officer has published comprehensive guidance for dentists on how to respond under the current circumstances, first on the 27th of February and then updated on the 5th of March and a further communication on the 9th of March. So we would advise dentists to follow the advice from the Chief Dental Officer and proceed accordingly.
Thank you. And then just before we wrap up, just some things that have arisen from some of the comments that you've made, which I just want to clarify, if I may, so that everyone absolutely understands. First of all, on this business of visitors to hospitals, are you saying that you're going to be advising hospitals, all hospitals, that they should ban all but essential visitors?
Yes, that is essentially what we're saying. Obviously, in the case of parents and children, there may be particular considerations. In the case of end-of-life care, there may be particular considerations, but the presumption should be against trying to reduce as much visiting as possible.
And thank you. On the postponing of elective care, one comment that's come back on social media is, why are we waiting until the 15th of April before implementing that rather than going into it straight away?
So we're giving local services the ability to do that straight away if they believe that is the right thing from the point of view of staff training or the beds that they require. And so just to be absolutely clear about it, the letter that we have issued to the NHS today says, assume that you will need to postpone all non-urgent elective operations from 15th April at the latest for a period of at least 3 months, However, you also have full local discretion to wind down elective activity over the next 30 days as you see best, so as to free up staff for refresher training, beds for COVID patients, and theatres and recovery facilities for adaptation work.
And the local discretion is also important because we don't expect the epidemic to necessarily be at the same level in different parts of the country at the same time. So there are good reasons for allowing organisations to act locally according to their circumstances, both in terms of staff, operations, but also in terms of what's happening in ters of the infection locally.
So, I mean, the corollary of that is that, of course, we would, if the opportunity presents itself over the next several weeks, we would like as many people to be able to have their operations as they possibly can. And not just in NHS facilities, but if there are opportunities in local independent hospitals, we are strongly advising that people take that opportunity too.
Thank you. And you gave a very clear answer earlier about cancer, but how likely is it, as things look now with the modelling that we've got, that other urgent treatments, for example, strokes, heart attacks, or trauma treatment after a road traffic accident, might also end up getting postponed and people might not be able to get the treatment they would normally expect from the NHS?
Now, those are emergencies, and in suggesting that we can see a route to freeing up 30,000 of our 100,000 hospital beds, the implication is that the other 70,000 are likely to be used for heart attacks and for strokes and for major trauma.
So you're planning to keep your capacity for emergency as
capacity for emergencies.
Okay. And then just a very specific one from one doctor about cancer patients, which is that she has noticed that a number of the major London teaching hospitals, you can still go into the cancer waiting rooms where people are waiting for chemo, and you can see patients squashed up very close together, and there doesn't appear to be any guidance that people should distance themselves because of the COVID risk. Is that something that you could take away and issue some guidance on if that's appropriate?
Yes, I think we can, and also because cancer patients under active treatment are in that high-risk group, advice will be included within the general advice we're providing over the next few days to those very high-risk individuals.
Thank you. And then just a final question, if I may. So, I mean, I would say that the two biggest concerns that NHS frontline staff are, one, the protective equipment, which we talked about earlier, but secondly, this issue of rapid staff testing. And I appreciate this is a matter for PHE, and I know that before you, Sir Patrick Vallance said that they are really wanting to rapidly scale up the testing, and he envisaged it moving onto South Korean lines, which has about 10 times more capacity than us. But I just wondered, from your perspective, as things stand today, where there is this advice that you should self-isolate for 14 days if one of your kids gets a fever, and that's obviously, does that worry you in terms of NHS staff capacity, that we could lose vitally important people unless this problem is resolved quickly?
We are concerned about that. So there are two very specific things that we're enacting to the NHS today, and Amanda can run you through both of them.
Okay. So just to say, we would completely agree with what Sir Patrick Vallance said about the importance of ramping up testing, and that's absolutely going to be, I suspect, an important part of the longer term strategy. But as Simon says, in terms of what can we do today, what we have done is issued in the guidance that we've sent out today that we should be offering all staff who wish to take it, so entirely voluntary, the opportunity to have NHS reimbursed hotel accommodation so that they can continue to work but don't have to go back to a place where they might come into contact with an infected family member. So that's entirely voluntary, but we know that that is something that people have asked us for, so we're trying to respond to that very quickly. And the second thing we're doing is working with PHE to stand up, again as a matter of urgency, some testing for those symptomatic NHS staff who, if they turn out not to have coronavirus, can return to work straight away rather than having to go through that period of self-isolation.
So, just so I understand that last comment, or the penultimate one on the hotels.
Yeah.
So this is obviously not people whose daughters developed a fever, because they would, as things stand, have to stay in isolation for 14 days unless they got a test that was in the clear. This is people who are not in that situation but might want to move into a hotel so that they can avoid the possibility of having to isolate if a member of their family got ill. Is that correct?
No, it is the group of people for whom, say, exactly as you say my daughter came home from school and had a bit of a temperature. At the moment, as per Keith's explanation, you wouldn't anticipate somebody, if they themselves were to be infected, to be symptomatic and to have any risk of infecting other people for the initial part of the time that they've been exposed to a family member. So actually the risk is that you continue to stay exposed to that family member for an extended period of time, and then of course you can't work because you're at much higher risk of both getting the virus and passing it on unless you have been tested, and we know definitely, and the staff member knows for themselves, that they are negative. But for the moment, what we would want to do is say to people, if a family member has been exposed, then absolutely, if you wish to continue working, as long as you're not going home to that person, then if we can offer you accommodation that allows you to continue to work so that you're separated from that family member, then we would wish to be able to do so. Now, clearly, in that circumstance, if somebody then became symptomatic, we would expect them to, as now, then immediately remove themselves from a work environment and do all of the things that we've issued as guidance to anyone who finds themselves in that situation.
But so I understand this. So you are satisfied that if someone's has a family member who becomes symptomatic without doing a test, it's okay for them to carry on working in the NHS with vulnerable patients without doing that test if they live in a hotel separately to the family. That's the advice you have.
So I'll let Steve come in, but there's a bit of judgment.
This relates particularly to the new policy introduced yesterday, which is if a family member becomes symptomatic, then the rest of the household should isolate for 14 days. And clearly that has an implication for NHS staff, and as you have alluded to earlier, we have heard very clearly from organisations that of the potential impact of that. So this is one way, and it's absolutely not for everybody, for exactly the reasons you described earlier around home circumstances. But for some somebody who's relatively become symptomatic and say, actually, I'd like to continue working for a period of the next few days. I'd like to have accommodation so that I can continue working. It is an option, but it's absolutely not for everybody.
Because I just want to understand, because obviously you're NHS England medical director, that if you have a symptomatic family member and you work for the NHS, rather than self-isolating, it is okay for you to carry on working. It's safe for colleagues, safe for patients, providing you leave your family and stay in a hotel. That's clinically you're saying that is safe for people to do that.
Clearly it depends when the symptoms started for that symptomatic individual, but if the symptoms have started, for instance, when you were at work, if you get the phone call, the symptoms have started, or you've been on call overnight and not been there for a couple of days, yes, because as we said earlier, the infectious period is during the symptomatic period. But it's absolutely not for everybody, and it needs to be used with discretion.
Yeah, I would say this is about getting them. I've got two choices here. So somebody who's had an exposure, be it a very mild early case exposure, saying, right, we're not going to lock you in quarantine alongside someone who we know is going to become more virus spreading over the next sort of 48 hours and become unwell. Park you out, carry on, but we'll watch you very carefully. And if you do get any signs of infection, then you'll go into self-isolation. If you've been with them all weekend and you've been exposed, then clearly that would be inappropriate.
Isn't there a safer solution just to put that particular person right at the front of the queue for the next test?
Well, the test duration, what are you going to do with them? You're going to put them in a hotel, I guess, aren't you? You've got to separate them. You don't want to put them back into the environment where they're at risk. So
the other number I think is correct, Chair, which is that we need a lot more testing capability for NHS staff. As it happens, the first in the queue should be symptomatic NHS staff rather than the asymptomatic family members of somebody who themselves, their relative is in isolation. But as we get more testing, we absolutely want to be able to test NHS staff as quickly as possible so that they can then get back to work if they are negative.
Final quick question from Dean.
I just wanted to jump in on that, which was akin to your question really around the testing piece of it, because Are you saying that at the point that tests do become available, with that guidance, the first instance would be to test them rather than put them in a hotel?
The first instance will be to test symptomatic NHS staff, and then the wider net will be the group that we've just been describing, yes. And that's why we are obviously very enthusiastic that Public Health England, the Department of Health procurement team and so on are able to expand the volume of testing available in this country.
So our priority at the moment is clearly to test patients, and that's right. Staff would support that. But as testing ramps up, our absolute next priority, as we have said, is to ensure that NHS staff are tested. One, so that they know that they can come back to work if they are negative, but actually knowing who has been positive is also important, because we will then be developing a group of staff who will have immunity to this disease and will therefore be more confident in their ability to provide care.
It's a busy, busy time. Thank you for being so generous with yours. Thank you.
The proceeding has ended. 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 The proceeding has ended.